Okay, so we are at the top of the hour, colleagues. Welcome to our August 2022 ECHO session. My name is Francis Ochen from the African Society for Laboratory Medicine. I'm your host today. As usual, this session will run for 1 hour. I will take presentations and dive into the questions and answers. Kindly join the discussion through our chat room, and we will have language interpretation services. It is key that you then choose one of either English or French. Also to note that our first presentation will be in English and the second presentation will be in French. And so you need to choose a language of your choice so that you can then be able to get the services. In our session today, we look at measuring the progress and value of integrated sample transport network for clinical and public health benefits. Access to healthcare, we know, including diagnostic services, is one of the dimensions of quality. And with regards to diagnostics, services are staggered through the healthcare system network with simple procedures at lower facilities and more complex procedures at the higher levels of the network. An effective sample referral system allows clients to access the full range of services irrespective of where they seek services from without having to move from one service point to another. The same goes for public health practice that require lab data for their routine use. We also know that countries have embraced sample referral as a strategy, and many existing national sample transport network continue to move towards integrating the integration so that they can then derive value from the services provided within their network. In this session, we will highlight the progress and the best practices for evaluating the quality of integrated sample transport network to improve clinical care in Zimbabwe. And then we will also highlight findings, lessons learned, and proposed recommendations from the specimen transport network for severe acute respiratory illnesses in Burkina Faso. In doing this, we will have two presenters. The first presenter is Agripia Mutambara. Agripia is the National Integrated Sample Transport Coordinator for the Ministry of Health Zimbabwe. And after the presentation from Zimbabwe, we will then have Sulaiman Pago. Sulaiman is the consultant and the national focal point with the Integrated Transport System for Biological Samples in Burkina Faso. Colleagues, without taking much time, allow me invite Agripia Mutambara to take us through the first presentation. Over to you, Mr. Agripia.
Thank you, Francis. Hello, everyone. Thank you once again for affording Zimbabwe to share its story in specimen transportation. Before I proceed, can you confirm if you can hear me loud and clear?
Yes, we can.
Thank you. So I'll take you through the Zimbabwean story with regards to the National Integrated Specimen Transportation System. Okay. Yeah, to help me with that, I'll walk you through the background history, the design and planning, program management, how are we managing the program, how are we monitoring the program, and a few key messages. As far as our background is concerned, the public health system in the country has got about 1,672 facilities. And these range from the primary care facilities to the tertiary healthcare facilities. And along this tertiary structure, only about 130 of them have got a functional diagnostic laboratory. If we then look at what has been happening, what has been our trigger to then come up with integrated specimen transportation. We experienced this fragmented transportation where we had several players coming in. Some of them would find situations where specimens are collected from patients or clients, and probably they are taken by a courier service, or maybe they are taken by whoever presents themselves at the health facility, or some patients would be referred to those health facilities where the services are available. And obviously, movement would be a challenge. We had some courier. We also had some partners coming in the district that they were supporting, and they would bring in parallel models to make sure that transport movement within their programs, they would work. So basically, we had these fragmented parallel systems which were operating, and they were not documented, neither were they coordinated. So with increasing need for diagnostic services, find that the increase in viral load, increase in EID, increase in TB management, full blood counts, all these disease patterns coming through, that was the major trigger to then say we need something that is coordinated and then operate. And most of all, making sure that this is efficient and cost effective. So this has led to the ministry and its stakeholders. When we say stakeholders, with various departments within the ministry, we also have our funding partners. We have had them to sit down to design and come up with an operational hub and spoke model for integrated specimen transportation, which is what the current country is currently using. At the design and planning, this was a participatory approach. We were using the viral load and EID diagnostic network optimization as a leverage to make sure that we optimize the use of the various investments in equipment that we have, making sure that we place these pieces of equipment in optimum positions or optimum or strategic testing labs where they can provide the services. And you find that we're also considering the issue of POCs, where they are placed and so forth. Then we also considered various other disease components, including malaria, including TB. We also have our environmental department. We also have the epidemiology and disease unit, epidemiology and disease control unit. Then we also have our partners or our funders, including PEPFAR, CDC, the Global Fund, CHAI, UNICEF, Chemonix, USAID, just to name a few. So we together all these stakeholders and had a participatory approach. And we also used the LabCoP software to make sure that we model our IST. And the LabCoP software, it helped us to gain coordinates for all the health facilities and then see where they can actually refer their samples. And eventually we came up with a hub and spoke model with a provincial approach. The country has got 10 administrative provinces, and we settled for a provincial approach where specimens will be picked up from the primary health facilities, come up to the hubs, and when they get to the hubs, they are tested for those that have tests that are available at that level. Then they are referred to the provincial level for those tests that are not available at those district or collection hubs. Then for those tests that are not also available at the provincial lab, they are also designed to find their way to the reference or tertiary labs. And the system was designed in such a way that it moves both specimens and results. And what were the outcomes? We're looking at, came up with 341 clusters. Infrastructure of 280 motorbikes was needed to service those 341 clusters. To make sure that We have movement in between the hubs and the provincial testing labs, as well as the tertiary testing labs. We also came up with a need of 8 vehicles. And how are these or hubs or primary care facilities then serviced? Rural clusters, they were designed to be serviced 2 to 3 times per week, and urban clusters were designed to be serviced 4 to 5 times per week. And as part of this planning, also came up with operational needs. What were our operational needs? The human resource component, the personal protective equipment, including the riders' gear, the riders' boots, helmets, and so forth. Triple packaging to make sure that we maintain specimen integrity. And obviously, the motorbikes and the fuel, the provincial vehicles, they would need fuel as well as service and maintenance. So we came up with this full infrastructure and also the operational needs, and we then costed them, and then approached our funding partners to say this is what the ministry would need to make or to have a functional operational IST. If we look at those 2 maps to the right, we have a demonstration there of the hub and spoke models or facilities that are in the hub and spoke model. It's unfortunate the print might be small, but this map is just meant to demonstrate the distribution of the hub and spoke model, or the distribution for facilities, which one is a hub, which one is a spoke. Then also that triangular diagram at the far right bottom there is showing our tiered network in terms of the health system. We will have the rural health centers at the bottom, go up to the rural health centers, they form the spokes. The district and mission hospital, they form the hubs. The provincial hospital labs, they form the provincial testing labs. Then the central and national reference lab, they form the tertiary testing level. So our system services all those levels in an organized structure. Then this is our national coverage, looking at from 2019 when we started having the coordinated approach up to where we are. Earlier on, around 2017, we actually had demonstration districts. We did that in 3 districts, and we found that the hub and spoke model would work. 2018, we then come up with, that's when we came up with the design that I've already alluded to earlier on. And when we look at 2019, the map at the bottom left corner there, that's when we then rolled out the national approach. And with the level of saturation, we're at about 43% in terms of saturation. And it was taking us about $671,000 US dollars for the running costs or for the operational costs for the system. Then as we go up, you find that the red and yellow colors, they are then changing into light green. And if we go up to the very last one up there of July 2022, we are at an operational cost of about 2.6 million US dollars per year. Then one would ask, why do we have why are we increasing in terms of amounts? Does it mean that in 2023 we also have more in terms of the operational cost? If we put that into context of the coverage that I've already displayed, you find that if you compare the map for 2019 and for 2022, they are different in terms of saturation levels. What has happened? What has happened in between? We've had an increase in infrastructure, increase in number of motorbikes. Currently, we're at 92% saturation, where we have about 260 out of the required 280 bikes. 2019, we're at around 70 bikes, and if we compare that, that's a big difference. And operational cost of running around 260 bikes at the moment is around 2.6 million US dollars per year. This is how our system is coordinated, or this is how we are operating our system. We have the Ministry of Health and Child Care with full ownership of the integrated specimen transportation. If we then also look at our far left corner there, we have our funders there, comprising of PEPFAR, CDC, UNDP, the Global Fund. They were part of the development process. They've also appreciated what the ministry wanted to achieve. And they've come in with the resources to say, we can provide your resources in terms of the capital needs, in terms of the operational needs. And how that has been modeled now is we have an implementing partner, which is BRTI, and TRUE, which is the ministry, and BRTI, we have a collaborative approach in as far as managing the integrated specimen transportation. And that then forms the organogram there, where we have an IST specific department within BRTI, and we also have an IST unit within the Ministry of Health and Child Care. And those two units, they work hand in hand with the regional officers. We've got 4 regional officers, and we've divided our country into 4 regions, where each regional officer is responsible for provinces within their catchment. We also have the provincial officers there. Then we have the riders right at the bottom, and we have the lab manager there. All these personnel, they are engaged within the Ministry of Health and Child Care, and the lab manager there is providing direct oversight to the riders there to make sure that whatever they are doing, they are within the confines of the requirements. Then program management, how are we managing our program? Rider oversight at facility level is offered by the lab through the lab manager there. If we look at our diagram there, left corner there, we have every morning before they go, the riders, they are with the lab manager. They make sure that everything that they need, even results, they carry with them. Second diagram there showing the triple packaging. They make sure that those riders have got their triple packaging, and make sure that temperature monitoring is also done. Then the rider is off facilities, they pick up the samples, the proper triple packaging that they've been trained to do. And after visiting all their facilities, they are back at the lab. So the rider starts at the lab and also ends at the lab. Physical monitoring, how do we monitor these riders? Through the lab managers there, we have the daily logs where they log in at the health facilities, and also at the clinics or rural health facilities that they visit. We also have physical inspection. The lab managers make sure that they carry out physical inspection for the riders, for the motorbikes on a daily basis. Then we also have the route schedule. This is the guiding document or the guiding direction or compass to say who goes where at what time and what day. Then in terms of remote monitoring, we've also loaded our bikes with trackers, and also what we call the OD system. This is an open data kit which collects data and information as and when they move around the clinic. Communication, this system requires lots of communication, and our communication is through phone, through WhatsApp, through email, whichever is applicable or available soonest. These are our monitoring tools. Unfortunately, they might not be very legible, but we just wanted to display practically what we are using in terms of the monitoring tools for the program. I have already talked about the IST route schedule. We have each hub or each cluster has got a route schedule to say where does the rider go, at what time, on what day. So our clinics, they actually have an expected time of arrival for the rider each and every day. Then we also have the specimen and result transmitter or register, which they use to track or which the system uses to track all samples that are carried through the system. And this one is still manual. If we look at the far right, there we have the electronic sample transportation system. We're actually venturing into the electronic bit to make sure that we reduce paperwork. Then, in terms of electronic monitoring, we have the ODK system there. That's the open data kit. Each rider has got a tablet where they use at each particular clinic that they visit, they capture, it captures the bike mileage logbook. Also, rider visits tool to say which facilities they visited. They also capture specimen and results that they've actually picked up or dropped. Also, the timesheet for accountability of the time that they're there. And the ODK actually picks up geo coordinates. Then we also have the geo tracker. Our bikes are fitted with trackers, and we can tell remotely where each rider is and at what particular time. How do we manage our fleet in terms of fueling and in terms of bike service and maintenance? Each rider gets their fuel once weekly, and this is calculated per distance that they cover. Then we have what we call fuel mini depots. Fuel mini depots, initially we were experiencing lots of dead mileage when a rider would go to a centralized point for fueling or issues of containerized fuel. But with improving experiences within the system, we've come up with location of fuel mini depots where our riders draw fuel at the shortest possible distance to minimize disruption of their routes and route schedules. We actually have a fuel inventory system, which draws system from the central level right down to the rider and make sure that we have uninterrupted service. Then in terms of service and maintenance, we've got scheduled service and maintenance, which is known because our riders, we know the distance that they travel. Then we actually have service provider contracts that we have a decentralized points in the country, and these they provide the service as well as field rescue as well as repair for bikes or vehicles that go down. In those pictures there, they show the infrastructure that we have. In terms of program monitoring, we actually track a number of indicators. There we have coverage indicators, then we have bike functionality indicators, then we also have specimen quality and integrity indicators. That's how we've grouped our indicators, and we have the specific indicators that we are tracking as displayed on that. Then we have, there is this as a demonstration of what, I mean, of our outputs in terms of some coverage indicators here. Unfortunately, the print might be small, but the objective of this slide was to demonstrate which symbols have moved and also demonstrate the integration. We have the left corner there indicating the viral load and EID symbols moved over time from the inception of the integrated specimen transportation. Those are quite high volumes there. To the top right, we have the sputum symbols as well as the urine lung specimens there. Then we have other symbols there, including stools, histology symbols that have also moved in the system. And why we've not combined those three graphs is because of the numbers involved. The viral load EID, and they've got very high numbers naturally in terms of moving across the system, while the other symbols, they've got low volumes. So the specimens that are moving through FBC, CD4, stools, and over the past 2 years, we had this pandemic, the COVID-19, and symbols were also moving across the system using the IST. Then this is a bike functionality indicator there. Our target there being 90% and above in terms of bike functionality. And bike functionality is a function of availability of the rider, availability of the fuel, mechanical soundness of the bike. And in situations where we have bike breakdown for any of the reasons, what do we do? What are our mitigation measures? We use the relief riders if the rider is away for one reason or the other. If it is the bike which has had a mechanical breakdown, we make use of a roving bike. Sometimes we have temporary rider rerouting where riders reorganize themselves within their hub to make sure that they service all the routes in case one rider is not available. Then also service and maintenance to make sure that we get back the bike as early as possible back on the road. Then we also have fuel buffer to make sure that we don't stock out in terms of fuel. This is the impact of IST on our pre-analytic and post-analytic turnaround time. This is what IST can contribute or control. So what we are saying here is with the increasing number of motorbikes from 115 in the first bar there up to about 257 where we are at the moment, we've also witnessed a great reduction in the turnaround time there, where initially we used to have it around 50 days. And in the last graph there is showing us around 9 to 10 days in terms of our turnaround time. So we've had a drastic reduction in turnaround time owing to the movement of samples on time and also movement of results on time. Then rejection rates, we've also witnessed massive rejection rates. Most of the reasons that are within scope of IST included samples missing or request forms missing, and these samples would be rejected at the hub lab. But with the introduction of IST, you find that all these samples they are pre-screened at the facility. And our riders, they've come clinic lab interface agents. They've brought in the missing link or the communication or the interaction, much needed interaction between the clinics and the labs, and that has improved service provision, and that is also witnessed the reduction in sample rejection rates. In terms of our key messages, every challenge is a chance to become a champion, right? So if we look at those animations there, that guy jumping the, I presume that's triple jump, then we also have the light there. How have we addressed some of the issues that we faced? Mileage visits to facility. We have instances where our riders have gone to clinics several times, they pick up 0 specimens. And we've already put in resources there. We've had to then engage into creation activities through the programs, through our clinical lab interface, through our partners to make sure that we generate a demand for testing services in those particular areas. We also have roads and also hard to reach areas and areas where we have human-wildlife conflict. This came to realization upon rolling out the system. So we've come up with mitigation measures to make sure that vehicles operate in those hard to reach areas and game areas to make sure that our riders remain safe. Then for mechanical breakdowns, I think I've already spoken to those where we use either roving bikes or relief bikes. In relief bikes, we have areas where we have additional bikes. We also have areas where the ministry also provides bikes from the pool of the bikes that we have. Then bottom left speaks to fuel. We've not been in terms of fuel price hikes. And we've always gone back to the funders and made sure that we get the necessary adjustments. Then rider fueling distances and containerized fuel, I think I've spoken to that already. We've mitigated that through introduction of mini fuel depots and also making sure that we have adequate buffer stocks. As I finish off, allow me to acknowledge our stakeholders in IST. Starting there with our ministry, we've got the PEPFAR, CDC, the Global Fund, UNDP, BRTI, USAID, we have Population Solutions for Health, World Health Organization, JAI, UNICEF, Chemonics, all these have played a very important role in making sure that our program becomes a success to where we are at the moment. Thank you very much for your time.
Thank you very much, Agrippa, and fascinating story from Zimbabwe, how you're doing the monitoring, how you're handling dead mileage, and I know many countries are struggling with this as well, and then communication. Allow me, colleagues, to move it to our next presenter, but keep your questions coming. Our next presenter is Sulaiman. Sulaiman is going to do this in French. Sulaiman, just make sure that you're on the French channel and please go on to do your presentation. Kindly note that we have 15 minutes to do the presentation. Thank you and over to you.
Est-ce que les gens...
Oui, allez-y.
Voilà. Merci. Donc, vraiment, merci à tout le monde. Et je m'appelle Sulaiman Porvo. Je vais vous faire l'état des lieux et les perspectives du système intégré de transport échantillon biologique mis en place au Burkina Faso. Nous allons suivre en 6 étapes notre présentation. D'abord, une introduction, et la mise en œuvre, et nous allons aller avec les résultats, difficultés, perspectives, et conclure par la suite. Donc, en introduction, il faut dire que le système de transport des échantillons est un maillon important si nous devons avoir des échantillons de qualité. Voilà. Ces échantillons de qualité aussi permettent d'avoir des résultats de laboratoire fiables et opportuns. Et pour cela, il faut un système de surveillance performant. Voilà. Et cela aussi permettra, bien entendu, une riposte appropriée aux flambées épidémiques. Donc, c'est tous ces aspects qui ont fait qu'au Burkina, nous avons pensé à la mise en place d'un nouveau système que nous avons appelé CITEP. Auparavant, il y avait un système traditionnel qui était assuré par le personnel de santé. C'est le personnel de santé qui faisait le transport d'échantillons. Ceci avec un remboursement des coûts de transport et d'hébergement. Et aussi, il fallait que chaque programme organise son propre transport. Nous avons plusieurs programmes en matière de santé publique, la méningite, la polio, et ainsi de suite. Et ce qui demandait ou occasionnait des sources de financement divergents. Donc, nous avons fait une évaluation en 2016 de ce système traditionnel-là, qui a montré en fait les conséquences et les constats suivants. D'abord, le premier constat, comme on l'a dit, le transport était assuré par le personnel de santé. Cela augmentait la charge de travail de ces derniers. Il y avait aussi une coexistence des systèmes verticaux, comme on l'a dit. Tous les programmes, chaque programme organisait son transport. Donc, il y avait une utilisation non rationnelle des fonds. Et le système n'était pas bien coordonné, ce qui ne permettait pas un acheminement à temps d'échantillons. Il y avait aussi une faible contribution des fonds domestiques, et ce qui ne garantissait pas la plénitude du transport d'échantillons biologiques. Donc, par rapport à la mise en œuvre d'un nouveau système, il faut dire que cela a commencé en novembre 2016, où il y a eu... Cela a été possible grâce aux contraintes occasionnées par ce nouveau type de transport. C'est pour le transport des infections respiratoires aiguës sévères, les prélèvements des SIRAS, qui demandaient qu'il y ait un délai raisonnable dans le transport. Entre le prélèvement et la réception au labo de référence, on ne devait pas dépasser 48 heures. Et cela demandait aussi que les prélèvements arrivent en bonne qualité et que le transport soit vraiment bien suivi. Donc, au regard de ces contraintes, il y a eu un transporteur unique qui a été recruté, qui est la Poste Burkina Faso. Et au fur et à mesure, par rapport aux besoins, il y a eu l'intégration progressive d'autres échantillons, notamment la dengue. Donc, pour l'implantation au départ, il y avait plusieurs partenaires qui nous ont appuyés. Il y a ASLM et il y a CDC, à travers le Global Health Security Agenda. Et le partenaire de mise en œuvre était l'ONG Davicas International. Donc, nous avons ici cartographié les différents sites pilotes. Vous avez en rouge carré les sites pilotes pour les IRAS. Il y en avait 4. Et il y en a qui étaient au centre, d'autres un peu au nord, et après un site au niveau carrément de l'ouest. Il faut dire que le labo de référence pour les IRAS se trouvait à l'ouest. Il fallait que tous les échantillons puissent arriver à ce labo de référence en 48 heures. Et par la suite, vous avez les 7 autres sites que vous voyez en carré, en triangle, c'est le site d'Eng. Et là aussi, le labo de référence se trouvait à l'ouest, à Bobo du Lasso. Donc, vous voyez qu'il y avait des sites qui se trouvaient carrément au Sahel, vers Dori. Donc, l'évaluation de ce système-là, pilote-là, a montré une bonne performance et aussi une maîtrise de coûts. Les coûts ont considérablement diminué. Et au regard de ces aspects, le ministère de la Santé a décidé d'étendre ce système à toutes les maladies prioritaires sous surveillance. Donc, pour ce faire, il y a un groupe technique qui a été mis en place à partir de juillet 2019. Donc, le groupe technique a travaillé et à partir de janvier 2020, nous avons suivi le lancement officiel de ce site-web qui s'est effectué au cours d'une réunion, de rencontre préparatoire de la saison épidémique que vous voyez en image. Et cette rencontre a vu la participation des autorités administratives, des autorités politiques. Elle était présidée par Madame le ministre de la Santé et tous les autres même l'OMS, c'est l'OMS qui est assis un peu à gauche, la représentante OMS du Burkina. Donc, c'est un dispositif harmonisant le transport d'échantillons biologiques à tous les niveaux en utilisant un opérateur unique qui est à la poste. Comme caractéristique essentielle qu'on peut dire pour notre site web, il bénéficie d'une plateforme électronique Stellar qui fait la traçabilité des colis et accède aux résultats en temps réel. Il y a aussi une couverture de tous les sites de prélèvement et un système de numérotation unique à partir des stickers que nous mettons sur chaque prélèvement. Et il y a aussi une collecte régulière des colis au niveau des sites expéditeurs et une livraison au laboratoire de destinataire en 24 heures. Donc, nous avons ici un schéma qui montre un peu le circuit de transmission des échantillons. Vous avez à gauche les niveaux de soins, le niveau primaire que nous appelons CSPS. Après, nous avons les centres médicaux, ce sont des hôpitaux au niveau district. Et après, nous avons les hôpitaux régionaux, CHR, et les hôpitaux nationaux, CHU. Donc, les prélèvements se font à tous les niveaux. Et à tous les niveaux aussi, il y a des transports qui se font. Et après, les transports aussi se font de ces sites-là vers les labos de référence que vous voyez à droite. Donc, c'est des différents labos de référence qui existent au niveau du pays. Donc, nous avons aussi ici un schéma des ressources animales parce que quand nous mettons en place le système, nous avons pensé aussi au One Health. Donc là, vous avez le schéma des ressources animales et les prélèvements se font sur le terrain à partir des ateliers, des PV et qui vont directement au niveau des directions provinciaux, des labos de référence et ainsi de suite. Donc, la mise en œuvre du système a eu effectivement des coûts et nous avons ici répertorié les activités et les coûts. Pour la mise en œuvre, nous avons d'abord la recherche et l'identification des trains transporteurs avec l'appui d'un consultant qui a coûté à peu près 61 760 €. Et l'acquisition du matériel et consommable à hauteur de 149 769 $. L'élaboration et la mutualisation des supports, 19 300 $. Et donc, le coût total que vous voyez en haut, ça fait 555 072 $. Pour le fonctionnement, avec les éléments de coût que vous voyez en bas, le total se lève à 298 889 $. Donc, toujours dans les résultats, les acquis, nous pouvons citer d'abord le poster que vous voyez à gauche. C'est un poster qui montre un peu tout ce qui doit être fait à chaque niveau et chaque acteur. Il y a aussi un bulletin d'information que nous éditons trimestriellement. Vous avez ici des exemples qui sont affichés. Il y a aussi l'accord entre partenaires, c'est un document contraignant qui dit pour chaque année et pour chaque mois quel est le partenaire qui paye les factures de la poste. Donc ce document est signé en début d'année et permet vraiment de couvrir tout ce qui est dépenses de paiement des factures de la poste. Il y a aussi la convention, un document qui montre entre le ministère de la Santé et l'opérateur et le transporteur unique les différents éléments qui concourent au partenariat. Donc, une convention est signée. OK, donc cette convention, il faut dire que c'est la première fois que ça a été fait et ça a permis vraiment de faire le maillon, de que chaque partenaire puisse savoir quels sont les éléments à prendre en compte. On reviendra bien entendu sur les questions par rapport à ça. Les acquis, toujours, nous avons le guide national CITEP. Ce guide-là, c'est un guide d'utilisateur qui permet à chaque utilisateur de voir quelles sont les informations ou les actes importants à faire à chaque niveau. Donc, ce guide a été élaboré avec la participation de toutes les parties prenantes. Vous avez aussi une copie d'une fiche de notification. Et pour toutes les maladies, chaque maladie doit être accompagnée d'une fiche et chaque échantillon doit être accompagné d'une fiche. Et aussi, il y a toujours dans les acquis les helpdesk. Ce sont des bureaux d'aide à l'utilisation. L'image que vous voyez compte ici, c'est le chef de service de surveillance qui suit dans un de ces bureaux l'évolution des échantillons à tous les niveaux du pays. Donc, ces helpdesk se trouvent au niveau de la direction de la protection de la santé de la population. Au niveau du COURUS, c'est le centre d'opération d'urgence, et la DPV qui est la direction de la prévention par les vaccinations. Au niveau de la DPV, il faut dire que ce bureau est en cours et c'est même déjà terminé, il reste peut-être la réception. Il y a aussi des groupes de discussion qui sont mis en place et qui permettent un échange entre les acteurs. Et par téléphone d'abord, il y a aussi WhatsApp où tous les acteurs sont connectés, ils permettent d'alerter ou d'apporter des réponses à certaines préoccupations. Il y a aussi ici, nous donnons ici, en ce qui a été transporté depuis le 30 septembre 2021, depuis le début jusqu'au 30 septembre. Donc, nous avons à peu près une année. Donc, vous avez les VIH, les prélèvements de VIH qui sont majoritairement prélevés, près de 3 919. Et vous avez le VIH, la méningite, la tuberculose, les IRA, syndrome grippaux, la rougeole, les arbovirus. Et actuellement, il faut ajouter la COVID et les PFA qui ne sont pas pris en compte et qui ne sont pas aussi des moyens. Comme difficulté, nous pouvons saluer d'abord la collaboration entre les acteurs du CITEP. Il y a toujours quelques bisbilles qui existent entre acteurs et nous privilégions la communication dans ce sens parce qu'il y a de nouveaux données qui viennent. Bon, il y a certaines informations qui ne sont pas bien données. Donc, nous mettons en avant la communication et la sensibilisation pour résoudre ce problème. Les zones à défi sécuritaire et les zones d'accès difficile. Donc là, il a fallu imaginer la conduction des ASBC, agents itinérants, pour ce faire. Aussi, le manque de financement, CITEP. Bon, cela, nous continuons à faire des plaidoyers auprès des partenaires techniques et financiers pour résoudre les gaps. En perspective, l'extension du CITEP au niveau de CSPS, nous comptons en tout cas couvrir tout le pays progressivement. Il y a aussi l'amélioration du mécanisme de suivi de la qualité des échantillons transportés. Là, c'est un mécanisme que nous mettons en place pour s'assurer que les échantillons arrivent en qualité avec des données bien claires. Amélioration du mécanisme de paiement aussi des factures de la poste pour que si un partenaire paye, qu'on puisse avoir une traçabilité là-dessus. Et aussi la pérennisation du système. Ce sont des éléments de perspective. En conclusion, nous pouvons dire que si aujourd'hui le CITEP est fonctionnel, c'est grâce à l'engagement des partenaires. C'est la clé même du succès de la pérennisation du CITEP. Aussi, le fait que le transporteur unique a une couverture nationale, ça a bien facilité l'atteinte de certaines performances. Et nous trouvons que ce succès vraiment est très, très unique et capital et pourrait servir aussi comme modèle pour d'autres pays. Donc, nous ne pourrons pas finir notre présentation sans remercier en fait tous les acteurs, tous les partenaires qui ont contribué à la mise en place et le fonctionnement de ce CITEP-là. Et nous faisons une mention particulière à ASLM, CDC Africa, CDC Atlanta, et l'OMS, Nichols Group, et le Global Fund, PADS, avec lequel nous avons signé une convention, et aussi FINE. Merci bien pour votre attention.
Merci beaucoup, Sulaiman. Thank you again. And I'm glad to have this very comprehensive presentation with very key ingredients covered that can support really learning for the other members that are in attendance. We have now time to dive into the questions and answer session. And I will start with a few questions that have already come through and they keep coming. Again, thank you to Chidza and Nora who are already dealing with some of the questions in the chat room. And for just the greater use of everyone who is in attendance, we will deal with some of this right about now. So our first question is coming in from Awandem Ernest, and Awandem is asking, how do you respect specimen storage conditions in the context of integrated sample transportation? If you have whole blood samples or frozen samples along dry blood spot. And this question also comes from Ellen, so you could just deal with this question at once. How do you deal with different conditions that are required for different samples in the context of integrating sample referral network? I can throw this to Agrippa for now.
Thank you, Francis. Let me take that question and say we've actually considered the different conditions that our samples require. From the clinics to the hubs, we do not have any frozen samples, but we have specimens which require cold chain conditions. So we've provided triple packaging conditions. Then we also have separate containers which then also carry samples or DBS samples which then do not require any specific low temperatures, and also the other specimens that do not require low temperatures. From the hub to the provincial testing labs, we have the 8 provincial vehicles that I've talked about, and they're actually compartmentalized, where frozen samples can be put in one section. Those specimens that do not require any temperature specific requirements, they are put in those compartments. So we have thought and considered the issue of different samples requiring different conditions. Thank you, and over.
Thank you, Agrippa. I will still hold it with you, and just help me deal with this question that is coming in from Opiu and a few other colleagues. And their question is around ownership of the integrated sample transport network and sustainability. So who owns the sample transport network, but also for the short and the long term, what are your strategies to ensure sustainability?
All right, thank you very much. Allow me to say sustainability is one big consideration that we put on the table when we're designing this system. So this system is wholly owned by the Ministry of Health and Childcare. And yes, at this point, the ministry is strained in terms of resources. So we've gone out to then say to our partners or funders to then say, can we have this proposal on the table? Can you then fund us for this? And looking at our proposal, to sound enough, partners have come in and gave us or funded the various components of the program. And looking at issues of sustainability, we are looking at this program being totally engraved within the ministry structures to make sure that everything or all the operations, they're happening within the ministry. And we've considered the funding models to then say which is the cheapest and which is sustainable. And are we able to win ourselves off the partners or the funders and do this on our own? And the answer has been yes with that model. At an opportune time when the ministry is sound enough in terms of in the finances, the ministry can easily take this over and sustain and proceed through. So it's just for this time, the kickoff that we have our funding partners having assisted, but we can actually take over and run the system. Thank you, and over.
Thank you, Sulaiman. Sorry, Agrippa. Now, Sulaiman, I'm getting to you quickly. There is a question coming in from the French channel, still related to sustainability. And Elizabeth is asking or commenting that it looks like from your presentation and the discussions that we've had so far, that supporting the integrated sample network is so dependent on donors. How do you see Burkina Faso getting out of this situation, or will you keep it with the donors for the foreseeable future? Over to you, Sulaiman.
Oui, merci. Mon nom c'est Flavien Aké et je fais partie de l'équipe avec Sulaiman. La réponse vraiment simple est la suivante. La mise en place du système à la base est effectivement beaucoup supportée par les partenaires. Ce n'est pas évident qu'un ministère de la Santé mette beaucoup de ressources à la mise en place d'un système nouveau dont il ne connaît pas encore l'efficacité sur le terrain. En général, ces systèmes sont mis en place dans un premier temps par les partenaires. C'est ce qui a été fait au Burkina. Comment est-ce que cela peut être pérennisé? Eh bien, c'est tout le travail que nous sommes en train de faire. Premièrement, le fait d'avoir contracté avec la Poste Burkina Faso, qui est une structure pérenne et qui est une structure gouvernementale, facilite la collaboration entre le ministère de la Santé et cette autre structure gouvernementale pour, après, les opérations de paiement qui peut être facilitée parce que nous sommes dans le même gouvernement, dans le même État, d'une part. Donc, la pérennisation du service est établie et la facilitation des systèmes de paiement des factures est aussi facilitée. Deuxièmement, la ligne budgétaire pour le paiement des factures mensuelles est déjà insérée dans la ligne du gouvernement, dans la ligne du ministère de la Santé. Donc, la ligne de paiement des factures existe dans le budget du ministère de la Santé actuellement. Seulement, cette ligne n'est pas encore alimentée, donc nous continuons à dépendre de l'OMS, du Fonds mondial, de CDC Atlanta, qui continue à nous aider à payer les factures. Donc, toute notre activité aujourd'hui tourne vers la pérennisation, donc la remise en main de tout le système au ministère, afin que la ligne budgétaire qui a été tracée puisse continuer à puisse maintenant être alimentée et résoudre le problème de dépendance par rapport aux partenaires. Voici la réponse que nous pouvons donner. Si vous remarquez, il y a déjà 3 ans que la plateforme existe et elle continue de fonctionner. Over.
Thank you. Thank you very much. A very comprehensive and informative answer that is. The second last question, given that we're running low on time, but we'll still monitor the time and see if we can squeeze in another. The next question is coming in and it is related to still the cost. And Agrippa, you made mention of the $2.4 million that you're spending every year, and that looks like a very high figure. Do you want to break it down? I know the Burkina team did break down the cost elements that are involved, but the 2.4, do you want to break it down, what that covers? Is it just the maintenance of bikes, bike fueling and all, or does it even go to some costs that are related to lab processes in your integrated sample transport network? Over to you, Agrippa.
Thank you very much. Let me say the 2.6 million that we're talking about. Remember, if we look at that slide there, is talking about escalating costs or increasing saturation. So that is speaking to bike fueling, is speaking to bike service and maintenance, is speaking to riders gear. It's also speaking to carrier boxes. It's also speaking to triple packaging that is coming in for to improve issues of specimen integrity. So it appears high because we still have some costs that are engraved in there is setting up, but we'll still wait to see how the picture is like in the following year. So as soon as we reach saturation, we should be able to then see those costs either stabilizing or starting to recede. Thank you, Ndova.
Thank you very much. And for countries that have different amounts that they're spending in running their network, and you can also put in the context, please share with us in the chat room for the next remaining minute or two. Now we have one last question that seems to be more skewed to ASLM, and I will ask my senior colleague, Dr. Pascal, to take this up. I think Dr. Pascal is still online, and the question is coming in from Olufisayo, and she is asking, what is the organization doing to ensure that this integration is being covered in other countries as well? Dr. Pascal, if you're on, please deal with this.
Thank you, Francis, for putting me on the spot. So I guess we are talking about integration of testing services, including specimen referral. So that's a topic of importance indeed, where ASLM is really thinking a lot together with other stakeholders. And when we talk about integration, yes, there is integration on platform, on testing platform. There is also integration of the specimen referral. There is integration of reporting, etc. And you will see that this is a topic that will come in our annual meeting of the LabCoP, where we are going to try and find best practices on how to integrate diagnostic services, either through improved LIS, improved policies, improved procedure. So, you know, it's a vast topic that I cannot answer into 2 minutes, but suffice to say that it's really going to be the topic of a lot of discussions and consultation in October, and before October and through the next months to come on how we are going to implement integrated diagnostic services. Thank you, Francis.
Thank you very much, Pascal. I'm sorry for putting you on the spot without prior notice. Now, we are coming to the end of this session, colleagues. Thank you very much for having a very interactive session, very informative, fascinating, from Burkina Faso to Zimbabwe. Now, quick final comments from the presenters, and I will start with the Burkina team. Sulaiman, your closing remarks in 30 seconds.
Et juste vous dire merci à ASLM et tous ceux qui ont participé à cette conférence. Vous avez nos contacts, on est prêt vraiment à partager notre expérience. Et nous n'aurons pas les mots pour vous remercier. Parce que grâce à vous, nous avons pu partager l'expérience de Burkina. Nous sommes toujours prêts à le faire. Merci bien.
Thank you very much, Sulaiman and team. Over to you, Agrippa, for your closing remarks.
I'd want to say thank you, everyone, for taking time to listen to our experience, and I would want to say this is well attended, and I hope this has generated interest and also opened up avenues or strategies or to those who were doubting. I know probably you guys would all say, let's give it a try. It's doable. We've started from zero, and this is where we are. Otherwise, thank you very much, and good evening.
Thank you very much, Agrippa. And colleagues, your certificate codes are on the screen. Please make sure that you can get the certificates. The session slides, some questions were coming to that effect. The session slides will be available on our online resource center in a day or two, but also we'll be sharing this on our group's WhatsApp and the other social media platforms that are available. keep some of those questions coming. We will deal with them. For critical questions, we'll pick them out and make them part of the resources that will be uploaded and shared with you. I see questions on whether riders do only the pickup of samples or they do the packaging or they do additional roles as they handle the transportation. And different countries are, of course, dealing with this differently. And that is the reason that we keep sharing, so that even when you're already miles away with your implementation of the integrated sample transport network, you can still learn a thing or two from the implementation of other different teams. Until we meet during our next session from the ASLM team, we wish you the very best of your remaining part of the day. Over from us, and thank you for joining in.
Security of health,
LabCoP.
Development of the labs,
LabCoP.
Knowledge exchange,
LabCoP. Thumbs up, LabCoP International.
Dates 23rd,
LabCoP.
Promoting adherence,
LabCoP.
Monitoring the patient,
LabCoP. Thumbs up, LabCoP International. It's a learning network of disciplinary country teams, creating knowledge, sharing information. LabCoP. It brings the countries together to share laboratory practices, all the success stories, promoting viral load monitoring. LabCoP. Work together to improve laboratory systems. We respect one another regardless of our nation.
Security of health,
LabCoP.
Development of the labs,
LabCoP.
Knowledge exchange,
LabCoP. Thumbs up, LabCoP International.
Dates 23rd,
LabCoP.
Promoting adherence,
LabCoP.
Monitoring the patient,
LabCoP. Thumbs up, LabCoP International.
LabCoP, Laboratory System Strengthening Community of Practices, is an amazing project led by African Society for Laboratory Medicine. LabCoP is fully funded by Bill and Melinda Gates Foundation.
LabCoP. We work together to improve laboratory systems. We respect one another regardless of our nation.
Security of health,
LabCoP.
Development of the labs,
LabCoP.
Knowledge exchange,
LabCoP. Thumbs up, LabCoP International.
Dates 23rd,
LabCoP.
Promoting adherence,
LabCoP.
Monitoring the patient,
LabCoP. Thumbs up, LabCoP International.
Any African country can join LabCoP International by submitting a letter of support from the Ministry of Health, identifying a multidisciplinary team that includes laboratorians, clinicians, program managers, and civil society.
Thumbs up, LabCoP International.